Controversies and consensus, that's what it's labeled. So the format of the next 30 minutes is we'll go over 20 questions around PJI controversies. Not all are controversies, but important practical guides. For each question, we'll spend 1.5 minutes. So for the first 20 seconds, there will be a question on the screen. You'll all be voting, so you'll have a link to how to vote on this. And then the next 40 seconds, we'll get a, yeah. Right now itself, you can scan that and keep it ready. Has the link gone onto their WhatsApp? Link on the WhatsApp groups. There's also a link on the WhatsApp group. You can look at that also. And then we'll have a 40 seconds for the response from the panelists. Then another 30 seconds to give a consensus from what the international consensus meeting in Istanbul, what have they said about it. For those who are unaware, because even I was unaware 6 months back what the format is. I had a chance to go there in May 2025, that's Dr. Parvizi, and he's the one who has started this way back in 2013, had one more in 18, and this one was 2025. So you can see how big the audience is, about 1,000 delegates. This is the format they had. They had 300 PGI questions. This was given to a work group of experts around the world, and some of our stalwarts from India themselves were experts for some of these questions. Then a work group from around the world was created for each question, and that work group did a literature review about that question. And what a literature review means is that they funneled all the data, all the titles, and then narrowed it down to about 300 abstracts, narrowed that down to about 30 full articles, and then studied those, and then came up with a consensus. This consensus was presented at the ICM in front of these 1,000 invited delegates. So it's not like any delegate can come and attend. They are all invited because of their expertise. And the voting was done by the delegates on whether they agree or disagree. The final document is yet to come out. That will be in July. But at least we know the consensus statements. So everyone has got the link and able to see, right? Okay. So we'll start with the first one. Is there a role for the use of personal protection systems, that is surgical helmets, spacesuits, in the prevention of PJI? So, yeah. So a lot of us get confronted with this. Should I do this whole setup, which I don't do normally for my other patients, or not? So we can see the timer, 4 more seconds left. So there are about 80 of us for and about 60 against. So now I'll ask the panelists, starting with Dr. Ojas on the extreme left. What is your practice and do you feel it's needed?
We are not using it, but if due to the cost constraints we are not using it, also I feel it is not that much required to prevent PGI. But if it can be used, you can use it. But I think the consensus is that it doesn't make a difference.
Yeah. Any difference of opinion from the panel? No. So yeah, in terms of the answer, there is no high-level evidence that personal protection systems reduce the incidence of PGI. In contrast, inappropriate use may increase contamination of the surgical wound. So this is the consensus out of the ICM.
Kushal, I give you a practical situation.
Yes, sir.
In the middle of the surgery, you have put the prosthesis on.
Yeah.
Nobody is using any personal protection system, and you get a hair on the implant.
Hair?
Hair, human hair you
Fair
find
enough,
on the implant.
Fair enough, sir.
Where does that come from? That comes from the surgical team, one of the surgical team members, yes?
Yeah, so this is just the evidence that it hasn't led to any difference in infection rates. Totally understand the logic, sir, but this is just
so there will be very different opinions, but the consensus is meant for that. So that's the whole idea of the consensus, is that we all think, based on our experience, we think so many things, but there's a consensus, and we got to respect the consensus.
Sure, sir. Do intra-articular injections before primary arthroplasty increase the risk of PJI? So intra-articular injections, because we are in the age of extreme use of PRPs especially. So does that lead to any increased risk? About 10 more seconds left. You can just say yes or no. So we can clearly see the majority are saying yes. So Dr. Jayashah, do you agree with that?
Yeah, there is a higher risk.
So what do you do then when you have a patient who's come with intra-articular injections?
Normally, I would wait for about at least 3 months, before I want to do a joint for this patient.
Any
data out there is very mixed. It's generally between 2 to 3 months. Most of the papers will talk about.
I would like to differentiate between intra-articular given in the hospital by
Sorry,
us.
Can't hear you, sir.
We want to differentiate between intra-articular given in the hospital and the PRP is done outside.
Okay.
PRPs, I would blanketly wait for 6 months. Injections, we have given steroids, I would say 3 months.
Any different timeline from the experts? 3 months is what most of them are agreeing on.
I would wait 6 months.
6 months. Okay. So this is the consensus. Yes, there is an increased risk of PJI when intra-articular injection is performed within 3 months of primary hip and knee arthroplasty. Beyond that, it's considered safe. So if there is any usage, just wait, because many a times we get tempted. Patients come to us, they sometimes hide the history. So important to elicit that history and then wait, delay the primary arthroplasty for 3 months.
No, Kushal.
Sorry.
Can I use two seconds for that?
Yeah, of course.
Yeah, because I wanted to use this platform to tell and to warn the orthopedic surgeons not to give PRP for degenerative arthritis. It is not acceptable by any guidelines, and in fact it is under the purview of Telangana Medical Council, and tomorrow you may be penalized. I'm telling you, there are a lot of quacks in the form of pain specialists, and myself and Sudhir Reddy waging a big battle, and we have gone to Telangana Medical Council. It is under sub-jurisdiction. That means under the court. And so do not take it lightly. Orthopedic surgeons, I'm telling you, youngsters, whether you charge 2 lakh rupees, 2,000 rupees, it's immaterial. It is not given in any guidelines, starting from American Academy to Telangana Orthopedic Association. So do not, same with viscose supplement. Do not put any injection into the joint. Please, please, please.
And stay away from rheumatologists.
Yeah, absolutely. So please don't do that. I'm appealing to you. Tomorrow it will be disaster for your practice because you are all under the scanner. So PRP is the biggest scam of the century. So do not do that and do not encourage that. Thanks, Kushal.
Thank you. All right. Question 3, does the use of antibiotic impregnated PMMA cement reduce the incidence of PJI in those undergoing primary? So we're not talking about a revision setting. This is a primary setting. Should we use antibiotic impregnated cement or not? So audience, again, it's a mixed view, but tilting in favor of yes. So that's our response from the panelists. Dr. Ramana?
Yeah, I think it's not required in routine cases, but in high-risk cases where long-standing diabetics, immunocompromised, you can use it.
Okay, so your answer is no. Anybody else? Any difference? So you're of the opposing view. Evidence among lower level comparative studies is mixed, but level 1 evidence as well as pooled registry data does not support a reduction in infection risk in primary joints. So that's, as Dr. Ramana said, in your routine primaries, you don't need to use it. If you feel it's a high risk patient, you want to use it, no harm in doing that. So in doubtful cases for PJI, what is the best intraoperative test to confirm or refute the diagnosis? So we mean sometimes you open the joint and you're a little confused as to some of the material that's there, or you want to be sure maybe pre-op parameters, ESR, CRP were a little lopsided. So intra-op test to confirm or refute the diagnosis. Dr. Kasha, any take on this? The voting says frozen section.
Frozen section, yes.
So that would be. Any difference in the panel, Dr.
I would
Jaisha?
probably say the first one, leukocyte esterase.
Leukocyte esterase. Okay.
It's easier to do it, and you get an answer yes or no over there.
Yes or no. Fair enough. Based on the diagnostic accuracy, the availability, time to result, and cost efficiency. If you take all these together, either of these three are useful. So whichever you have, whichever is available, please go ahead and do that as a to confirm or refute the diagnosis of PJI. Is there a role for joint specific, that is hip versus knee cutoffs for your synovial tests or your serum biomarkers? That means ESR, CRP or any synovial tests, the values of total count or differential count inside the synovial fluid in the diagnosis of PJI. So difference between hip and knee, should we have any such cutoffs? So most people are saying yes. Okay, almost equal. Dr. Sudhir Reddy, anything?
No, not in my opinion.
Yeah.
I'm not aware.
I think that's a straightforward one. So based on the current literature, there is no significant difference in synovial fluid markers in patients with PJI for hip or knee infection. So you can use the same parameters for both sets of patients. So this was the question I think Ratnakar was asking. Should joint aspiration be performed in patients undergoing revision arthroplasty for presumed aseptic failure? So you are doing a aseptic revision. Should you still aspirate it even if you are sure that it is aseptic? CRP are negative, no signs clinically. Majority are saying yes, so everyone wants to aspirate. We'll go back to Dr. Ojas. Would you do it even if you feel that it's non-infected, clinically and serologically?
Yeah, I would like to rule out a PGI, a suspected PGI.
Okay.
So I will be doing it.
Any difference from the panel, or everyone aspirates irrespective?
If there is a significant effusion, I'll probably aspirate.
Okay. Anything
To
from
have
the
some
front row?
clinical, suspicion in that regard. If the joint is completely dry, completely cold and, clearly long-standing aseptic, long-standing joint that has led to aseptic loosening, I wouldn't aspirate.
You wouldn't do it, yes.
So if you've got your tests done and your tests are all negative, and you know the cause for the failure, which you can see on the X-ray or something, then
so that's what we would think. Even we do that, but the recommendation is yes, all joints undergoing revision for assumed aseptic failure also should be aspirated. So irrespective, of course.
Kushal, I was a part of this panel. I think the relevance here is that roughly 18 to 20% of so-called aseptic grow positive cultures. So it is really to circumvent that option that this recommendation was made.
Yes. Optimal duration for holding
one
cultures.
Kushal, sorry, previous one. Is that the same evidence for knees and hips?
Yes. No
For
difference.
all?
Yeah.
So no, the aspiration.
Correct.
So every case, even if you're thinking aseptic, you have to do aspirate, whether it's knee or a hip.
Yes.
Right.
So optimal duration for holding cultures in suspected PJI. So 2 days, 1 week, or 2 weeks. So once you've done the surgery, you've taken out the samples, you've sent it to the lab, you look at the report at what point of time, and till when do you ask your microbiologist to hold those cultures in the lab. We'll go to Dr. Jayasha. The majority are saying 2 weeks. Do you agree with the?
You should hold it for 2 weeks at least.
2 weeks, yeah. Excellent. So it is recommended to hold the culture for at least 2 weeks. But if you have fungal or mycobacterial infection which is suspected on your staining, then the samples should be held for an extended duration, 4 to 6 weeks. So just keep an eye out for that. Should intraop culture be obtained in all patients undergoing revision? So earlier question was about aspiration. Now you've done your surgery, aseptic failure as well. Should you still take those samples and send them? So majority are saying yes. We'll go to Dr. Neelam.
Yeah, I think you should take all 3 to 5 samples.
3 to 5, irrespective of your...
Yes, yes.
So fair enough. I mean, unless it's going to be a traumatic revision, for all the others, even if it's for a assumed aseptic, you must go ahead and get the culture samples. Next question. Next one, please. Yeah. Is there a role of bone scans? So we all talk about blood, ESR, CRP, everyone knows about aspiration. This bone scan is a grey zone. So is there a role, yes or no? As expected, the audience is split on this. So we'll go on to Dr. Kasha.
Yes, of course.
In what way?
So any long-standing cases, so whenever you suspect PJI, so you will get some information, not concrete, but yes, it is suggestive from bone scan.
Anything, any difference of opinion?
So if you've got, if you're doing just a normal bone scan, that's not indicated because that's going to be hot even at 1 year, 2 years after the joint. If you want to do a bone scan, it has to be labeled with leukocytes. Then you can go.
So what will that tell you?
So that will probably tell you whether there is a, there is probably a source of infection. Now, the best thing about a bone scan is if the bone scan does not show that the joint is hot, then you can safely say it is not infected.
Yeah, superb. So that's what I was waiting for. So it has a role, but it's a limited role. It's useful when serology and synovial tests can't refute or confirm the PJI diagnosis. So it's the negative test which is really useful more than a positive test. So negative test helps to rule out your PJI. So this is the importance of bone scan. Next, please. Is aspiration necessary prior to reimplantation? That is stage 2. Because now you know that you have done your stage 1, ESR, CRP are down, clinically you feel it is not infected anymore, you're ready for your stage 2 at 6 weeks or 12 weeks. Should you still do a aspiration? I think this was also the question by Ratnakar. Yeah. So again, split verdict. What would you do, Dr. Sudhir?
No. if serological markers are normal, there's not much effusion. Clinically, it seems to settled. I will not aspirate.
Any difference of opinion from the panel? Anyone in the front wants to disagree?
Many times, if you actually try to aspirate, you don't get any fluid.
Yeah, dry tap.
Most of the time it ends up being dry tap.
In the dry taps, does anyone put saline inside and try to get any sample? No.
Not done ever.
Yeah, so routine aspiration of a joint prior to reimplantation is not necessary. Aspiration should be individualized based on the type of joint, the type of infection, the clinical course of treatment, among other factors. So if you still suspect something's wrong, your ASR, CRP are not behaving as you wanted them to, that serial downtrend which is bookish is not happening, then you can consider it. But routine aspiration is not necessary. So is there a role to repeat DIAR in patients who have acute PJI? So you've done your DIAR. Timer, please. Okay. You've done it once and you still have no success with the DIAR, but it's too soon. Maybe your implants are still well intact. It's too soon after surgery, either 6 months or even if late onset but acute. Would you still repeat a DIAR or is it a waste of time? Dr. Ojas.
I would say no.
Because the no is the answer, yes. So the audience is, no. Has anyone done it before? Any experience with it? Any success with the repeat DIAR from the experts?
I'll just give you one anecdotal case. I mean, one DIAR I had done 3 years back, a different bug. 3 years later, a different bug, and comes with similar a short history, in no symptoms in the intervening period. And it's a different bug altogether. So, a repeat DIAR was done. But that's a different situation altogether.
It's not the situation at all. Here is a situation, say 2 weeks, 3 weeks, you do a DIAR, and then still not settled down, then 5 weeks you do another DIAR. That's another complete different scenario.
What would you do, sir, for that?
That I would never do as a two-stage.
Two-stage. So most of us are tending to that. The consensus is possibly a repeat DIAR appears to increase the overall success rates of infection eradication. So that's an option. If you feel, because by that time it's too early and you don't want to remove that implant, as sir said, 3 weeks and 6 weeks, these kind of window periods after, if you want to attempt to redo your DIAR, then it is justified. It is not a crime.
The point here is your principles of DIAR must be well laid out. For example, if you don't do a poly exchange and then after 2 other weeks go in again and then add a poly exchange to it, like that.
Fair
so
enough.
When you say DIAR, in your hands, what is DIAR, you must define it and do it.
Correct.
Otherwise, you'll be keeping doing this half-hearted procedure.
Done correctly, yes.
I think with DIAR, the most critical ingredient is the timing of the DIAR.
Yes.
If you do it within the first 2 weeks, max 3 weeks, you have the best chances of success. And from the onset of symptoms to intervention, that ideally should be 2 weeks or less.
Having said that, there are instances where there is a good success rate even after 1 year. In some cases, all of us do that. Yeah. So. Okay.
Yeah.
Kushal. Right.
So that's the next question then. Does the type of infective organism influence the success rate of your DIAR? Question on screen, yeah. So we're talking about doing the DIAR, but knowing from your aspiration that this is your organism, would you change your thought process or would you counsel the patient differently that this success rate is changing? So most people are saying yes. Dr. Jayasha, do you?
100%.
Yeah. So what kind of thought process goes through your mind?
If you have a bug which is like a staph aureus or a cons or something of that sort, they have a lower success rate after a DIAR.
Absolutely.
That is well shown in literature. Multiple studies have shown this.
Yes. So yes, DIAR success depends on the infecting organism. More virulent organisms have poorer outcomes, like was mentioned, MRSA, enterococci, gram-negative, and fungi. Now, what are the absolute contraindications to performing a one-stage, so single-stage exchange arthroplasty for those with chronic PJI? Timer is not on, please. Yeah. No. Yeah. Absolute contraindications. Would you not do it for culture negative, or if there is a sinus tract, or if there is extensive bone loss, all the above, or none of the above?
No, none of the above. Istanbul, none of the above.
Yeah. So mixed. Yeah, quite a mixed bag of responses. So I'll go to Dr. Ramana.
I think the indication would be a culture negative PGA.
Sorry?
Culture negative PJI, I would not do a single
Culture
stage.
negative. But the other two you are okay with?
I don't do it, but I think those other two are okay.
Understood, yeah. Anyone does it here in the...
So if you go by the guidelines right now in the ICM,
I have done
it's none
in
of the
culture
above.
negative PGIs as well.
Sorry?
I have done in culture negative
You have
PGIs
done
as well.
it. Fair enough.
So
Dr.
if you-
Jaisha, yeah.
If you go by the last guidelines at ICM right
Correct.
now, it's probably now going to change to the last option, none of the above.
Yeah, excellent. I mean, we are just showing what is presented in the guidelines. So, there are no absolute contraindications to one-stage exchange arthroplasty. However, relative contraindications may include systemic sepsis, immunocompromised patients, and extensive soft tissue defects that don't allow you to close the implant. Now, what do we mean by that? We are disregarding all of these things: culture negative, presence of sinus tract, extensive bone loss. Of course, we are still getting used to that culture of single stage. We've done about 32 single stage revisions in both culture negative and culture positive, and we get about one reinfection till now, but that also has happened in the culture positive. Very less data, but whatever data is available till now, this is the consensus.
So the message for the audience is to the consensus that we think that we put some antibiotic cement for 6 weeks, it will sterilize the wound. That doesn't seem to be happening here. It's got no advantage by putting 6 weeks of antibiotic. It doesn't seem to be doing anything. So whatever you're going to do in the second stage, if you're going to do it in the first stage and have the appropriate antimicrobial therapy, that seems to be the consensus. That's where it's going, evolving around that consensus. That putting that cement for 6 weeks, we think it's going to sterilize the wound. Nothing like that is happening. So that's the consensus.
Yeah, Kushal, one other thing to think about contraindication is probably fungal infections, because this probably the tide has turned by the randomized control trial that came out of Ortho Carolina, where they did multi-center single stage versus two stage, and they showed equivalent outcomes for all comers, sinus tract, MRSA, doesn't matter organism, except the things they excluded are fungal infections.
So that question was specifically asked,
Okay.
fungal infection and single stage revision, and they said it's not a contraindication.
Wow,
So
okay.
there is no contraindication as of now, except for these other relative contraindications.
Yeah, Kushal, can you go ahead? Go ahead.
Okay.
Yeah.
How long do antibiotics elute from PMMA spacers? 2 weeks, 2 to 6 weeks, 6 to 12 weeks.
I think
So you
it is
put a
2
spacer
weeks.
in, how long will that spacer work? So majority is saying 2 to 6 weeks. Anything from the
I think
panel?
it is 2 weeks.
2 weeks. Any difference of opinion? 2 weeks by Dr. Ramana as well. So, although many confounding factors influence antibiotic elution over time, available data indicates it, the MIC is maintained for 6 to 12 weeks at least, and that's the whole reason why we keep that spacer in there for that much time and sometimes delay your stage 2 for up to 3 months. So that antibiotic spacer is working for that long. So slight difference of opinion there. Is there a difference in success rate of two-stage exchange when static versus articulating spacers are utilized? So we are talking about articulating and static spacers. How will they impact your two-stage revision? Is there any difference? Which one should we be using? Yeah, so correct. That's a very good point. What is defined by success? So first let's see the answer, then we'll go to that. Split verdict. Anything from the panel? Yes.
Not the success rate itself, but the range of movement and the easy rehabilitation will be better with articulated spaces.
Any other difference of opinion? Yeah, so excellent point made. Yes, although both articulating and static spacers yield similar results in terms of infection eradication. So if that's your success, then it's equal. But otherwise, articulating spacers offer better functional outcomes without significantly increasing the treatment costs. What is the limit to the number of exchange arthroplasties in patients who continue to fail treatment for PJI? So you've done your exchange arthroplasty, that means either a 1-stage or a 2-stage exchange one time. Then would you not consider doing it twice? Would you still continue doing it 3 times? So limit to the number of exchange arthroplasties. So many of us are going to even 3 times panel. So we were at Dr. Ojas, yeah.
There is no absolute limit, as it is not like once you have done it or twice you have done it, you will stop doing it. As long as you feel it can be proceeded and the host factors allow it, the medical condition allow
So
it.
you're saying you would continue your revisions 2-3 times also?
If the first was single stage, then second can be done 2
Fair
stage
enough.
also.
Okay. So assuming that prior surgical procedures were carried out properly, patients failing a second exchange arthroplasty should not be subjected to additional reconstruction surgery. So after failing once and then again redoing that revision surgery, if it continues to be infected, you should not subject your patients to further reconstructions. Go for either arthrodesis or amputation as you prefer. How soon after treatment of patients with PJI can success be declared? So is it, when can you truly say that the patient is free of your infection? At 1 year, 2 years, 5 years, or never? So again, a split verdict. We'll go to Dr. Jaisha.
So the data shows 2 years, but then they still have to be followed up for even longer than that.
Anything else? Any difference of opinion from the panel? Yeah. So failure after surgical management of PJI can occur at any time. So that's the dictum. But for assessing the success of your treatment, a minimum follow-up period of 5 years is recommended before you can truly say that you are successful with eradication. But for the purpose of our studies, trials, or evaluation of novel technologies, minimum of 1 year is recommended. So as you said, a longer period of follow-up up to 5 years. But we don't do that because we think patient has gone away and not come back to us. It's a success. Fair enough. Is there a role for extended oral antibiotic prophylaxis for patients at high risk of infection after primary total joint? So you think it's a high risk patient? Would you give him an extended oral antibiotic prophylaxis or no? And
this is gaining traction nowadays, according to the consensus also.
In fact, we are doing a study on it. Yeah. We've done about 2,000 patients where we extended to 7 days in patients who we felt were high risk. So mixed reviews in terms of, panel, any take on that?
Yeah, I would extend.
You would extend it. Anyone?
Duration is something.
Would everyone extend? Yeah.
Probably for a week.
That's what. So that's our feeling. We should, as of now, no. There is insufficient evidence to recommend the use of extended oral antibiotics in high risk patients. That's the thing. But I think in practice, many of us may be doing it. Yes.
There are some recent papers suggesting, in fact, 3 months to 6 months of oral antibiotics post second stage.
Yes,
there are recent papers in JOY.
Yeah. This is after a primary.
Oh, this is primary. I am sorry.
Yeah. So what is the optimal duration of antimicrobial treatment after DARE? So you've exchanged your poly and you've started the patient on antibiotics. Should you do a 2-week course, a 6-week course, or a 12-week course? So most are at 6 weeks. Dr. Kasha?
Yeah, 6 weeks.
About 6 weeks. So any difference from the experts at the front? Because even we do 6 weeks, but I was surprised to see that a minimum of 12 weeks of antibiotic therapy is recommended for those undergoing DARE. We don't... Longer. But this is for...
but the recommendation is 12 weeks. Or
12 weeks.
DARE must be treated...
I think these kind of things, maybe we can consider changing our practice for these kind of scenarios. Is there a role for the 2-week antibiotic holiday?
We have been routinely using 12
weeks. Yeah, it's very important. Is there a role for 2-week antibiotic holiday in patients undergoing 2-stage exchange? That means you finished your first stage, you are at your second stage. Before that, would you give an antibiotic holiday? Yes or no? Timer was not on. Anyway, most of the people are saying yes to an antibiotic holiday. Dr. Sudhir Reddy, anything?
Yes. In fact, I usually give 6 weeks of antibiotic holiday.
And reason for that?
So, you would know, you want the inflammatory markers to come down and stay like that. You don't want to come down and then start going up. If they start going up, then I would be worried that the infection has not been fully controlled.
How will your holiday help them to come down though? Antibiotic holiday.
So it will tell you whether the infection is really controlled or it's not adequately controlled. So you're better prepared for the second stage.
Okay. So would anyone not give a holiday?
And also, as I said, the cement itself keeps eluding some antibiotic. So the longer the interval, the higher chance of your success.
Kushal, on one hand, we justify a suppressive antibiotic therapy for people who are medically not very well. That means you are suppressing it. Then on the same line, 2 weeks antibiotic is just to make sure that 6 weeks was not suppressive therapy for that patient.
Yeah.
So there is no illogical thing you are following together. Yeah. Either you don't do suppressive or you believe that even here it could be suppressive, wait for 2 or 4 or 6 weeks, whatever you believe, and if it doesn't come back in that short period, you can always say it can come back after 1 year. but some period you have to give.
Right. Go ahead, because Sharon, hip is open, Sharon is pouring coffee in that. Okay.
So no evidence that a 2-week holiday improves the outcomes. So I think those were the questions. Thank you so much to the panelists.